Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today, we're going to talk about two articles from the journal, of which Dr. Benjamin Druss was an author. Very excited to have Ben here.
So we're very lucky to have Dr. Benjamin Druss, who is a psychiatrist and a professor in the Department of Health Policy and Management at the School of Public Health at Emory University, on the podcast to talk about a couple of articles. The first of them is a qualitative study of barriers and facilitators to transitions from the emergency department to outpatient mental health care. And the second one is supporting the mental health workforce during and after COVID-19. So we have plenty of interesting topics to cover in the podcast today. So welcome, and thanks for joining us, Dr. Druss.
Thanks, it's great to be here.
So maybe to start out, we're talking about two seemingly very disparate articles right now. Maybe just give us a little bit of sense of your work, your research interests, and your career path, and how you came to kind of have such a broad interests and areas of expertise.
Thanks. So I'm a mental health services and policy researcher whose work broadly focuses on populations with serious mental illness who are treated in the public mental health sector. Much of my work over the years has focused on the physical health of the population. But as you say, my interests are pretty broad and have actually gotten broader as I've grown older and moved through my career. I teach Masters of Public Health students about mental health and how it fits in to public health. That's part of what's kind of kept me broadly interested. And over the past few years, I've been increasingly involved in the technical assistance world, which for me is an effort to take what I've learned through my years on the research side and to try to put it into practice in the field.
So how did maybe we can start with the ED transitions paper? How did this come into your lap, or how did this area of inquiry become interesting to you?
So emergency rooms are really the canaries in the coal mine for the public mental health sector. People often present there because they didn't have access to good outpatient care. Only about half of patients seen in emergency rooms for mental health problems make it to outpatient appointments after they are discharged. And relative to outpatient and inpatient settings, there's been a lot less ED research, in part because it's challenging to recruit and follow patients that are seen in those settings. So we felt like this was an important issue that needed to be addressed from both a public health and a scientific perspective. We knew how important contextual factors would be, both in precipitating an ED visit and then also determining whether people follow up. And qualitative research is particularly well suited for understanding these sorts of contextual factors.
And so maybe you could set the stage for the study a little bit. Like, where did it take place? Who are the participants? What sorts of questions are you asking them in the qualitative research?
Well, this was part of a larger study that followed people seen in emergency rooms for mental health problems and studying if they successfully transitioned to outpatient care at a community mental health center. The study was conducted in 8 emergency departments, 3 urban, 2 suburban, and 3 rural. Patients seen in the emergency room for a mental health diagnosis were assigned a care manager from a local CMHC with the goal of linking them into outpatient care. And then the study that we're talking about today that was published in Psychiatric Services was a qualitative study that examined the patient, provider, and system level factors that precipitated the visit and then that either helped or hindered follow-up after discharge. We conducted 45 interviews, 30 with patients, and 15 with the case manager providers.
And just to get a flavor, like what sorts of questions were part of the qualitative interview?
Yeah, I mean, they were organized around logistical challenges to getting care, things like financing or transportation, and patients' attitudes about care, whether they thought they needed care, whether treatment would be helpful, what might be keeping them. And also there were questions addressing issues at the for patients, for their relationships with providers, and then particularly with the providers about kind of systems issues that might be either helping or hindering patients from transitioning to outpatient care.
So, as you mentioned, you're approaching it from the client perspective, the provider perspective, and also the systems perspective in general. Do you have sort of like a couple take homes from what people told you about each of those buckets?
Sure. At each of those levels, we looked at both kind of patients' perspectives about their care, and then also the challenges for those who wanted to get care in getting it. So at the patient level, they describe hesitancy around benefits or need for treatment. One of them, for instance, said that I just kind of delayed it because I thought I was at a point when I could handle things on my own. Severity of symptoms kind of cut both ways. So it could make it harder to engage in treatment, but when people did engage in treatment, if they saw a reduction in their symptoms, that helped keep them engaged. Logistical factors, the most common barrier that kept people from following up was reliable transportation. This was a factor that was even a bigger deal for this setting, getting from the emergency room to outpatient care, than it is, say, for people who are already engaged in care, and is a bigger deal in part because many of these settings were rural, where transportation is challenging. Some relied on family members for rides. Those rides weren't always available. Those with Medicaid could use a Medicaid van to bring them to the CMHC, although the number of rides was capped. Financial difficulties made it hard for people who drove to afford gas or fares for bus or cab rides. Patients who were uninsured reported troubles in paying for medications or out-of-pocket fees for appointments.
So the social determinants of health, once again, show how important they are in people getting care. And interesting and different, perhaps slightly different ways in the rural areas around, with more of a focus on transportation. But it seems like it's the same theme.
Absolutely. Yeah, I mean, that was something that consistently came up. Often the same factors, many of the same factors that led to people using the emergency room were the very same factors that made it hard for them then to engage in care after they were discharged, and many of them were social factors. Yeah, absolutely. At the provider level, developing a connection with a provider in an emergency room, getting a warm handoff is very challenging. And that was done sometimes in person, and that seemed to work best, sometimes over video, and then sometimes over telephone. But a warm handoff was really important. And then at the system level, it's just important. One of the challenges in the study was that the EDs and the community mental health centers were separate organizations. It wasn't like one health system with a shared electronic health record or, staff that were credentialed, at both sites. There were two separate systems. So you basically, even when you had a care manager coming on site to an emergency department, they didn't have full access to the information, and they also weren't part of the organization. So, just that difficulty of moving not only like what was often a large distance between the emergency room and the community mental health center, but also across organizational boundaries.
Mm.
Did any of the responses surprise you, or did they confirm the hypotheses you had, or even less formally, did they sort of confirm your general hunches about what the issues were in transitions of care from the ED to the outpatient world?
Yeah, I would say that the biggest surprise was just how complicated and interconnected all of the challenges were that drove ED use, and that also made it hard to follow up with care. What's great about qualitative research is, as opposed to a survey, and certainly as opposed to claims data, is that you can look at how different factors interact with each other. And ED visits that just, were really commonly a common final pathway that were just this entangled confluence of mental health problems, limited options for outpatient care, financial challenges, social determinants, geographic barriers to care, and these kind of combined and fed on each other that would lead to a crisis necessitating an ED visit. And then, many of the same factors made it hard to follow up, creating a vicious cycle that just made it difficult for people to engage in care.
It also seems like it might make it hard for individuals caught up in that to actually really know what the issues are in their transitions of care. So you might ask somebody, why aren't you engaging in care? And they might say, I'm just not really ready. But then it may be that that's a proxy for all of the myriad things in transportation and crossing different systems and financing. So did you find that to be true, or that one thing isn't necessarily it might be a proxy for another?
Yeah, that's a really great point. Providers and health systems often implicitly or even explicitly put the blame on patients for using ED services. There's this term high utilizer that's used by health plans, sometimes by researchers. That's kind of stigmatizing, that implies that patients are somehow at fault for using unnecessary health services and ED services. In our state, in 2018, one insurer actually implemented a policy not to cover ED services that were after the fact deemed not to have been emergencies. So, the study really does highlight how ED visits are often a confluence of factors that are outside of the control of patients, and also how addressing it, you really need a multi-level approach that's addressing the patient and the factors, the provider factors and the system factors.
Ben, I know we want to move on, but I wanted to ask you one more question about this study. Obviously, in the last year, we've been talking a lot about social justice and structural racism and racism in general, and the intersection of all these factors. I know this study was done somewhat before this past year, but as you reflect on the findings, do you think there's something to be learned from your study about the impact of race, ethnicity, and the intersectionality of that with all these other challenges that people experience?
Yeah, no, that's a really good point. I think, again, I mean, what we were, what was so obvious in this was all of the structural factors that were making it hard for people to connect with outpatient care, and that were leading to ED use. So I think, there are clearly populations who are going to be more vulnerable to those challenges, all the structural difficulties, and particularly populations who are coming from, racial and ethnic minority groups. I would expect those challenges even to be compounded.
Yeah, it makes me
really
think
speaks. Yeah.
Oh, I was going to say, I think it makes me think that perhaps a next iteration or of this work might be to actually ask people directly how they think, or if they think racism or social justice issues affected their use of ER and follow-up. I think it's something that I think we can really try to be more proactive, I think, about trying to understand.
Yeah, again, it's a reminder that often we think of kind of how, what people do, how they engage in healthcare as under their control, whereas often it really is, there are just so many other complicated factors that are driving it, that are really important and that have to be addressed.
So speaking about challenging topics, the second article that we're going to talk about is about supporting the mental health workforce through the COVID pandemic and the aftermath of the COVID pandemic. We're lucky to have two out of three people here on the podcast right now who are real experts in technical assistance. So I'll be asking the questions from a more novice point of view, because I think that many of our listeners, and maybe myself included, know that there's a lot of technical resources out there. Use technical assistance resource, but I don't think of them in terms of like who's funding the technical assistance, how are they organized, what are the general goals, and are there various approaches to technical assistance across the country. Lisa, don't kill me that I don't think about this yet, but
well, I'm definitely going to keep you safe.
Okay. Thank you. I appreciate it. So could maybe both of you kind of comment on the general landscape about a technical assistance just prior to COVID, so that people can get oriented a little bit.
Sure, I'm happy to start, though we'll also defer to Lisa, who's been doing this a lot longer than I have. I'm relatively new to it, which is, perhaps gives me some, like you, Josh, I was sort of feeling around and trying to figure out what it all was and what the landscape was like over the last 3 years or so. But as I understand it, technical assistance supports the adoption and sustainment of evidence-based practices. There's a whole spectrum that can range from basic education and training, such as webinars and educational materials, through more intensive ongoing support, such as learning collaboratives that are really intended to change practice and outcomes. They're typically provided by specialized TA organizations that might either focus on one evidence-based practice, such as assertive community treatment, or multiple ones. And most commonly, they're funded by either state mental health agencies or at a federal level by SAMHSA, the Substance Abuse Mental Health Services Administration. So the one other piece of context is that in 2018, SAMHSA restructured a lot of the how it provided technical assistance activities. It shifted many of them to a regional model that has technology transfer centers covering 10 different regions of the United States, and then also established several national centers, including SMI Advisor, that provide in-depth training and technical assistance on key priority topics.
I think Ben did a great job of describing technical assistance. I would just add that the organizations that provide technical assistance, and we call them intermediary organizations. They have sort of this new name in implementation science. And what we need to understand is that technical assistance is but one part of actually changing a system and implementing a practice, whether it be an evolving practice, an evidence-based practice, practice-based evidence, whatever. Like when you're trying to bring something to scale, you have to do more than just train, as it were, the clinicians or set up the billing system. There's a whole array of things that have to be done. And when technical assistance is embedded in the careful consideration of and then deployment of all the other things that need to happen to make something work, then it's sort of it's facilitating, I would say, true scaling and implementation. So technical assistance is it's a very general term, but it really is a part of, optimally, it's a part of changing practice and changing the way that care is delivered and received.
So in the open forum, you have a great paragraph about this that I'm just going to go ahead and read, because I think it captures something about technical assistance, but it also alludes to the conversation we were having about the social determinants on the ED transitions paper, about that you have to think about things in a much wider context than just the individual level factors. So you write that the successful implementation of evidence-based interventions is affected by factors at multiple levels, both within and outside mental health organizations. These factors include characteristics of the intervention, the economic, political, and social context in which an organization resides, the outer setting, the structure, leadership, and culture of the organization, inner setting, the service users, clinicians, or managers who will be delivering their intervention, and the process by which the intervention is implemented. So you bring this up in the paper as an example of, could you think of something that would affect all of these various things more than COVID possibly did? And so I think that that's where we'll talk for the rest of the podcast. But I do think it was just an interesting way to crystallize thinking about implementation and technical assistance in general, about how it has to be really embedded in this much broader context than just what I experience as the user of clicking on something that seems interesting to me and that's going to help me in my clinical practice.
Yeah, and that's that's basically an implementation science perspective on what it takes to change practice, which is what Lisa was talking about. So for those who want a deeper dive on that, I'd point them to the implementation science literature in general, and in particular to Laura Damschroeder's consolidated framework. That really goes through all those different pieces.
Okay, so let's talk about how COVID has disrupted all of these various aspects and the behavioral health system in general. So the open forum is about the technical assistance organization that you mentioned, SMI Advisor, and how they're tackling a couple of the biggest challenges that COVID has brought up. So maybe you could just to start, walk us through what those challenges were, and by way of example, what SMI Advisor is doing to tackle some of those.
Sure. Yeah, as you say, COVID kind of changed everything from the actual, the interventions themselves, which needed to move at least partially virtually, to the rules and the regulations around things like telehealth that made it easier to provide telehealth at the same time that it was harder to provide in-person services, and real strains also on the workforce that was providing all of that care. So kind of looking at each of those factors, SMI Advisor has been working to help prepare the workforce to do more remote services through telehealth, also telesupervision, through things like webinars, infographics, town halls with leaders in evidence-based practices, discussing how they're moving virtually. With regards to fiscal challenges, providers have needed help in how to bill more effectively for telehealth, and also it's kind of necessitated a change, because so much of this has been changing so fast and is so local. A lot of what we've done is less top-down, kind of like we know what the answer is, and more sharing of best practices and experiences across organizations, trying to establish what best practices look like in billing. And then, finally, I think, TA historically has been a little bit more focused perhaps on the services than on the well-being of the providers who are delivering them. So there's been a need to really think about, self-care among providers, as well as, how organizations can help support providers through things like, childcare and support groups and things like that. So it's been a lot of changes, and it's likely that we'll be moving into some kind of new normal that won't be the same as the old normal from before COVID, but will be some kind of mix of virtual and in-person services. So it's just been a time, I think, that it's been important to be able to support the providers and care delivery systems.
Are you optimistic about the changes that COVID is going to have over the long term on the mental health service delivery system?
Yeah, I mean, I think that some of the changes, like the adoption of telehealth, had been overdue. But there is still work that needs to be done. It's not a panacea, and we need to find, what populations it's appropriate for, what settings it's appropriate for, what kind of evidence-based services it's appropriate for. I would say that I'm much more optimistic in general and about public mental health services in particular than I was 6 months or 3 months ago. There's a lot of good that's happening now. There's a lot of money that's coming down through the American Rescue Plan Act that's going to, infuse new money into the community mental health system, as well as expanding infrastructure and broadband and things like that that might have been challenges. Yeah, I mean, I feel good. I think that there's a real need, though. All this change and even all these new resources are also challenges for community providers and for states. They have to figure out, how to really create these new systems. So I think, there's a lot of, there's still going to be a lot of need for support for providers, for organizations, and for the states.
So before we close, this discussion reminds me that I need to thank Dr. Benjamin Druss for his service to psychiatric services over this last year, because Ben has adjudicated all of the papers on COVID-19, and there have been a lot of them, okay? And I will never forget, we were having a meeting, a telephone meeting right at the beginning of the pandemic for our policy work group, and I was sick. I had the virus. I don't even think I knew it at the time, or I was sleeping on the floor. I was so out of it, and poor Ben, he felt sorry for me, and he helped me follow up effectively for what was a challenge for the journal, and I'm very grateful. And I think your perspective on the pandemic is really important given what you've seen, I think, in all the articles you've looked at and processed. So thank you, Ben.
Yeah, it's been a privilege, and I feel like it's been a great way for me to really understand what's happening in the field, because I've got this kind of panoramic view that's really changed over time. Just, COVID has morphed from, a year ago worrying about, PPE and sanitizing doorknobs to now vaccines, and soon, what, things are going to look like post-pandemic. So, it's been really gratifying. There've been great articles that have come through. I think Psychiatric Services has really been a resource for the field to kind of demonstrate what's happening with COVID and what, where some of the challenges are and where some of the opportunities are. So I, Lisa, thank you for giving me that opportunity.
So from those heights, has there been anything that COVID has exposed in the public mental health system that you didn't know was a gap before the worldwide pandemic threw everything into disarray?
Yeah, I mean, COVID, completely, kind of blew up a lot of, maybe the stasis that the system was in before it was extremely disruptive. I mean, it exposed, as Lisa was talking about earlier, issues around inequalities and structural racism. I think it also highlighted workforce issues. There were real issues with burnout and recruitment and retention already in the public mental health system, and those really came to the fore and are going to need to be dealt with. Yeah, I mean, there were, a lot of challenges, but it also, brought out the best in a lot of providers and provider organizations. I mean, we've had some of these leaders of community mental health organizations present and host town halls. And I mean, they were just so creative and innovative.
Yeah.
And tireless and selfless in how they dealt with really just completely unprecedented. I mean, no one ever trained them how to deal with a pandemic, and somehow they rose to the occasion. So it's been very inspiring.
And SMI Advisor did a great job too.
Yeah, I mean, it's been a really good time to be able to be working in technical assistance, because there's just been a real need, and in a way we had to innovate as well, because it wasn't just kind of rote kind of marching through of the usual evidence-based practices. There have been a lot of needs to think about both the best ways of delivering technical assistance that's most helpful, and how to not just kind of be in a role of expert, but also something that's more interactive and kind of back and forth with the people that we're working with, because we're learning a lot from them also, and hoping to take what we've learned and bring that to the rest of the field.
Well, I think that's probably a great place to wrap things up. And thank you so much for joining us today to talk about both of these articles, and for all of the other COVID-related and non-COVID-related work that's in psychiatric services.
Thanks, Ben.
Yeah, thanks. Great talking.
That's it for today. We invite you to visit our website, ps.psychiatryonline.org, to read the articles we discussed in this episode, as well as other great research. We also welcome your feedback. Please email us at psjournal@psych.org. I'm Lisa Dixon.
I'm Josh Berezin.
Thank you for listening. We'll talk to you next time.
The views and opinions expressed in this podcast are those of the individual speakers only and do not necessarily represent the views of the American Psychiatric Association. The content of this podcast is provided for general information purposes only and does not offer medical or any other type of professional advice. If you are having a medical emergency, please contact your local emergency response center.